الله وبركاته. أنا Ahmad Taha. I'm a Dr. Taha from Anaesthesia department in Shams University. I work at a time in UAE in Health Point Hospital. Inshallah, today we'll discuss and make a workshop for lower limb blocks. I'm very happy to give this workshop because lower limb, there is a lot of surgery in the lower limb, and a lot of patients with a lot of comorbidities have limb surgeries. And unfortunately, the only two options with spinal and general anesthesia may not be the best option in a lot of patients. Thanks Allah, nerve block is very easy technique and can give you, can be enough for all surgeries of lower limb with no exception, even bilateral surgery. You can do it under nerve block. You can do hip surgery under nerve block, knee surgery under nerve block, foot, ankle, below knee, below above foot, amputations, orthopedic surgery, reimplantation, vascular, everything can be done under nerve block if indicated and if you think that the patient is risky to have the general anesthesia. The first slide here, before we start, you have to explain to the patient what you are going on. Because we are working in lower limb beside in the groin and in the gluteal region, so the patient will be shy. So you have to explain to him exactly what you are going to do, and that you are scanning this area to find the nerve. Also, two important points, that is neurological examination and pre-orbital assessment. Because you are the one responsible for the blocks. If the patient have pre-operative nerve injury, it should be detected in the anesthesia clinic. However, you are the one responsible. So if your colleague forget to examine the patient neurologically or take a full neurological history, you have to do this before inserting a needle and injecting local anesthetic. The second point is if you are working with a female, it's better to have a female staff available in the room, and she will help the patient to position her, to help to clean, to remove some clothes so you can scan certain areas of the body. So existence of female staff when the patient is a female, this is very important. Another point is you have to ensure that you have available block and emergency medication and equipment. We here, as you can see, that we have here the trolley for regional anesthesia, and few steps away, we have here the DC shock and the emergency card. All medication and all equipment that we need exists in this trolley. So this is a very important, and prepare your medication before you start. Even emergency medication, propofol, if you need sedative, bring it, make it available and prepare it. If you want some medication like atropine, we also prepare atropine before induction or giving a block. The next point is you have to insert an IV line. This is a very important. Don't give local anesthetic. Don't inject ever local anesthetic without inserting IV line and connect monitors. This is fatal. There is risk of last or local anesthetic toxicity, even with minimal dose of local anesthetic. So this is medical legal and also for the benefit of the patient. Insert an IV line and connect full monitoring, because at the time of the crisis, you will not look for the ECG, you will not look for the leads of the ECG. Everything should be prepared and connected before starting before starting the block. As you see here, we have here the monitors. We have to monitor these two rooms and even anesthesia machine. We have available anesthesia machine here for if in case of emergencies. Nowadays, COVID precautions should be taken very carefully. In our hospital, we are free hospital, COVID-free hospital. We don't have patients with COVID, and all staff is swabbed every 10 to 14 days. So all of us, alhamdulillah, we don't have anybody of us is test positive. Me and my colleague and our friend who will be scanned, all of us have been tested in last Thursday, I'm sorry. But in regular hospital, you have a risk that all patients here are swabbed before surgery. So we are free hospital, but this is not every hospital. In other hospital, if you can suspect it or you don't do COVID swabbing routinely for the patients, you have to take all precaution to protect yourself and to protect the patient. Now we'll start about the positions and what block to start. In lower limb surgery, we usually block one of two plexuses, the lumbar plexus and the sacral plexus. In the nerve, in the femoral and sciatic, femoral and obturator lateral cutaneous, and most of the blocks, it can be performed in the supine position. The sciatic nerve and lumbar plexus block both are performed in the lateral position. If you are going to do blocks, start with these two blocks first, the sciatic or lumbar plexus, because if you sedate the patient, it will be easy to bring him to the supine position if needed. But the opposite is difficult. Yani if you sedate the patient in the supine and you start with the femoral, to make him lateral position, this will be difficult. This will not be easy. So if you want to start lateral position, the blocks in the lateral position, then position the patient in supine, with the exception in the cases of the fractures. If the patient have hip fractures, this positioning him in lateral position will be extremely difficult. So we start with the femoral block first. So even some people, some physician operator give femoral block, even if they will give the patient spine, to facilitating the positioning of the patient. But today, for educational purpose, we'll start with the supine position blocks first, then we'll do lateral positioning blocks. So this is the first point, and now we are going to see the first block with us, which is the femoral nerve block. The femoral nerve block, the femoral nerve is this one in green. It is passing from the abdomen to the lower limb, deep to the inguinal ligament. At the level of the inguinal, but we do block at the level of inguinal crease, not inguinal ligament. And we do the block here in this area. Beside, as you can find, that is a nerve is just lateral to the artery. In all blocks, it's blocking. To do a block in ultrasound, it's like to finding an address. We need a landmark. In every block, we need a landmark. And when you scan the patient, we look first to the landmark. We don't look to the nerve. We have three major landmarks. The first one is the vascular landmark. And this is the most commonly used, like when you do supraclavicular block, when you do femoral block, when you do axillary block. The main landmark here is the vascular landmark. Another landmark and very easy identifiable landmark, it's the bone landmark. So the bony landmark may be used in some other blocks, like in paravertebral, like in the sciatic nerve, as we'll see after some times. Unfortunately, if we don't have these post two, we go to the third one, landmark, which is the fascial landmark. But this is the worst one because the fascial identification is lost when you are trying to do when the patient is obese or when deep blocks. So we have three landmarks. In very rare occasions, the nerve can be defined by spot diagnosis, and this is one or two, three nerves all over the body. The ulnar nerve, very few nerves in the body can be spot diagnosed, but in most of time we need landmark. In some blocks, the landmark, our nerve is just direct to the in relation to this landmark. In others, this landmark leads you to another landmark. So in some blocks, the landmark, like supraclavicular block, you find that is the brachial plexus is just lateral to the subclavian artery. But if you do scalene block, no, we start with subclavian artery as a landmark. Then we identify the plexus, then we follow the plexus up. So we may need some steps after identifying the first landmark. So inshallah, in the femoral block, our landmark in the whole supine position, inguinal crease blocks will be the femoral artery. This will be the starting step. And femoral artery, alhamdulillah, is a very easy identifiable landmark. So let's do. I'll put this in the middle. In the middle, don't worry. Okay, will be always covered. Don't worry. So this is the inguinal crease here, as you can see. It's a very clear skin landmark, and all the supine blocks, which is the branches of lumbar plexus, the femoral, and the lateral cutaneous, and the obturator will perform it at the inguinal crease. So the first step, we'll put the ultrasound probe here. As you see, I always put this one, the mark toward the left. So the mark here is towards the left, and the mark on the screen is toward the left. So when I insert the needle, so the mark to the left, and the mark on the screen to the left. So when I insert the needle will be not a mirror image. The needle will be a real needle. So we'll start and putting the ultrasound in the level of the inguinal crease, looking to the femoral artery. As you can see on the screen, This is the femoral artery here. It's very clear. And this is the femoral vein. The artery is pulsating. To improve the quality of the femoral artery, we change this tilting angle slightly cephalic. So I look slightly upward. And I make try and error until I got the best quality of the femoral nerve. So we look back to the screen. Look here. This is no tilt, and this is the probe is perpendicular. You cannot see the femoral nerve clearly. Like, look what I'll do now. With the small tilt, I do down, so you can see the femoral nerve is very clearly. The femoral nerve looks like a triangle. This is a triangle, and the base is directed to the artery, and the apex directed laterally. And the apex is my target. So I go with the needle from here. I am directing till this point. And once I go to this point, I slowly inject the medication, and I create to myself a space to inject more orthoful. Usually the femoral nerve, I block it with 15 ml. So this block is clear or need more? Any question about this block?
You can proceed.
Okay, so this is the femoral block, as we'll see again. So we'll put the landmark as the femoral artery. I put the ultrasound probe with the mark directed to my left thumb and looking to the artery. I tilt the probe until I get the best image of the nerve. And as you see here, the artery and the nerve. So this is the femoral artery. Okay? تعال بقى ياسر نجيب البروب هنا. تعال بقى.
Can you explain in plane out plane technique at the same time to finish this one?
Eh?
Can you explain in plane or out plane for the colleagues?
The needle, we usually insert the needle of in plane because this is a very, the distance between the skin, this is a very superficial block, and the distance between skin and the nerve is very small. So I prefer to insert the needle of in plane from lateral to medial.
I mean practically, you put your hand as you showed the colleagues.
Okay, I'll bring the needle and I'll show how to do it now.
Yes,
just a second.
Thank you.
Yes. Okay. So this is how we do this block. The needle is inserted from this point, from lateral to medial, and in the screen it will come from this direction. Okay, is this clear?
Thank you.
Okay, we go to the next nerve, which is the همسك ياسر خليك بقى انت صور لي من هنا ياسر بس روح كلوز بقى. The next nerve, which is the lateral cutaneous nerve of the thigh. طيب واضحه؟
Wonderful.
طيب. So the lateral cutaneous nerve of the thigh is passed to the thigh lateral to the sartorius muscle. This is the sartorius muscle, and the nerve passed just lateral to the sartorius muscle, and it's surrounded by a fascial socket. It's exactly like there is a socket of fat, and the nerve is embedded in between. So this is so our landmark is, as we said, in all these three nerves, the femoral and octolytical and lateral cutaneous will be the femoral artery. So we'll start as usual with the femoral artery, identifying the femoral artery. The second step, which will be identifying sartorius muscle. The medial end of the sartorius muscle is tapering end and is superficial to the artery. So if you look to the artery and then you look lateral and superficial, you will find the tapering medial end of the muscle. Okay? Then we follow the sartorius laterally, and on its lateral border, and usually this lateral border is curved, we'll find the lateral cutaneous nerve of the thigh. So let's see this. So I'll explain again from this slide, then I'll go back to the patient. So the lateral cutaneous we identified by identifying the femoral artery, then looking to the sartorius muscle with the tapering medial end. Then we'll go to the lateral border of sartorius to the other side, just follow with the screen with the ultrasound probe. On the lateral surface, we can find the lateral femoral cutaneous nerve. Lateral femoral cutaneous nerve, we'll speak inshallah tomorrow about its indication and how to block it. So the same point, we'll start here. We'll put the ultrasound probe with the mark directed to the left of my left, try to finding the femoral artery. This is the femoral artery. Then I go lateral and superficial to identify the most superficial muscle, which is the tapering end of the artery. So I go lateral, slightly lateral. This is the artery. As you can see, lateral and superficial, this is the tapering end, the medial end of the sartorius muscle. I'll follow this muscle till its lateral border. So we are going. This is a muscle, this is a muscle, this is a muscle, beautiful muscle. And on its lateral border, this border, we should find the lateral femoral cutaneous nerve. This is the nerve. In this patient, it has two branches, these two branches. So in that, sometimes in some patient, you find one branch in one fascial socket. Sometimes you find two branches in two fascial socket, and sometimes two branches inside one side fascial socket. You see this one and this one. So this is the sartorius, and this is the lateral femoral cutaneous. By the way, this muscle is named, or name is tensor fasciae lata muscle. So I repeat again. We go to identify. We go to identify the femoral artery, and then step number 2, identify the sartorius muscle, superficial and lateral. Then we'll follow the superficial muscle, the sartorius muscle, until its lateral border, and this at this point between it and the tensor fasciae lata, we'll find the lateral femoral cutaneous nerve. Again, here in the ultrasound screen, this is the femoral artery. This is the tapering medial end of the sartorius muscle. Follow the sartorius muscle laterally. Between the sartorius and the tensor fasciae lata, we'll find this fascial socket with the nerve inside the fascial socket. So this is the lateral femoral cutaneous nerve of the thumb. Clear? In this block, you can use, some people is talented and experienced, they can just redirect after they perform. Some doctors, after they perform the femoral artery like this, they can redirect the needle like this to do the lateral femoral cutaneous nerve using the same puncture point. If you cannot do this, no problem. You can reinsert the needle just from here, but just very superficial because the nerve is very superficial. So this is lateral femoral cutaneous nerve. By the way, also, when you are scanning this nerve, look to this, minimize the depths of the ultrasound. I use here the least depths of the ultrasound. In this machine, it's 1.5 centimeters. It gives you the best resolution. If you make the screen depths like this, you will not see anything. It's very difficult to see. The structural resolution will be less. You get it? Our target is here, so this is enough. So I make it the least depths to see my target. Only it's here. This is the lateral femoral cutaneous nerve. We'll go back to the octuretal nerve. Okay, so let's go to the next one, which is the obturator nerve. Okay. So next one will be the obturator nerve. Obturator nerve has two branches. It's coming from the obturator foramen here, deep to the Pectineus muscle. Then it gives two branches, which is just shortly. This red mark is the level of the inguinal crease, the skin. At this level, it gives two branches, divided into two branches. The one become above the adductor brevis and one below the adductor brevis. So the anterior branch above and the posterior branch below. The problem with the usual technique to block this nerve at two levels, above and below the adductor brevis, that is in the obese patient, or if the fascial gland is not clear, or if there is septum inside the muscle, you will not can identify which muscle is the adductor brevis. So it's difficult to identify adductor brevis, especially distal. Thanks Allah subhanahu wa ta'ala, we publish a technique, a proximal technique, that we can block the nerve just after it exits the obturator foramen. The nerve exits the obturator foramen in this area, just deep to the Pectineus muscle. So we place the local anesthetic just deep to the Pectineus muscle proximally, and that's it. How to do this block? First, we do again identification of the femoral artery. So the femoral artery we identified, then we go medially. We find this picture. This picture is an arrangement between three muscles: the Pectineus, adductor longus, and adductor brevis. As you see, these three muscles make a fascial layer like a Y letter in between, or Mercedes sign, inverted Mercedes, as you like. The point is between this Y and between the other side, on the lateral side here, the femoral artery, the Pectineus is one. So the next step, I identify the femoral artery. Then I go medially to identify the Y. Between the Y and the artery, there is the Pectineus muscle. Once I identify the Pectineus, I tilt the probe cranially. As you see, this is a probe perpendicular on the crease. I start to tilt the probe. Tilt to which degree? To the degree that I can find the bone, deep to the muscle. Once I find the bone, I inject just lateral medial to the bone. Inshallah, when I do this technique, you'll find this video. There is a very, very, very successful block. Even I did more than thousands of cases. It never fails except in 1 or 2 patients. But this is a very, very successful obturator block. It can be used for any indication for obturator nerve block, for TKR, for hip, for pituitary, for surgery of the bladder to avoid obturator reflex. So it's a very wonderful and very easy block. And you inject local anesthetic at one fascial plane, and it blocks both nerves, the anterior branch and posterior branch. Both are blocked in this one single level or one single fascial plane injection. We'll see this in the ultrasound. واحد من عندك؟ For obturator, you may need to do just some figure of 4 of the leg. I'll make your leg figure of 4. Okay, just like this. Okay, in this way. So you open the medial aspect of the leg. Then we'll do some alcohol. Take care that alcohol in this area is irritant to genitalia. So if you disinfect, make a very, very minimal amount of alcohol just at the site of needle injection, not spray alcohol as usual, because genitalia, scrotum in the male and labia in the female, it's very irritant by alcohol. Okay, so the third step, as usual, we'll go. We'll go to identify the femoral artery. Then we'll go medially to identify the Y shape. Then once we identify the Y shape, so between this Y and the artery, this is the pectineus muscle. I tilt like this until I find the bone. In this fashion, in this plane, I'll inject. Because the artery is here and genitalia is here, in plane is very difficult. So I use out of plane technique. So I inject in this area using out of plane technique. So let's go here in the screen. So this is the femoral artery, our first landmark in all blocks. We'll go medially to find the Y shape. As you can see, this is the Y shape. This is adductor longus, this is adductor brevis, and this is pectineus muscle. So I am sure that this is the pectineus muscle between the artery laterally and the Y shape medial. Once I got this picture, I identify the muscle. So the second step will be scanning cranially. So I go cranial with ultrasound, I find a bone. This is the bone here, and I inject medial to this bone. So I inject deep to pectineus in this fascial plane. So to just for label an image which is not important for block, this muscle is named the obturator externus, and this bone is part of the pubic bone. Okay, so this is obturator block. I go out to plane because I said from this area, this is the genitalia, and from this area is the artery and the saphenous nerve, saphenous vein and femoral vein, as you can see. So I don't want to come from here or from here. So I come perpendicular like this, and slowly I go here in out of plane technique until I find this fascia and inject in this fascial plane. I inject 10 ml, and this when I published it Anaesthesia in 2012, I used 20 ml, but this is no longer I use this volume. I just inject 10 ml here, and this is more than enough. Kam Yasser will show him how to use. So I will go like this. So I just stretch a screen, and just to find the point where I put the needle, then I go back to my position and start to push the needle. But the needle must be flush with the ultrasound probe. Not I insert the needle from here. I'll not see anything. So to see adequately, I have to insert the needle just flush with the probe. So I make the probe perpendicular, then stretch the skin, put the needle here, then come back to our previous position. As you can see in the screen, that's it. Okay, so I come from here. As you can see, and direct it here. This is bone. This is the fascial target fascial plane. Okay, clear. So I will repeat again. So the first step to put the artery, to put the ultrasound probe to identify the artery, then to go medial to identify the Y. Between both the Y and the artery, this is the pectineus muscle. I tilt the probe cranially until I find a bone. Once I find the bone, I stop I stop tilting the probe and starting to insert the needle. So again, this is the artery. I identify the artery. I go immediately to identify the Y shape, as you can see, and then I confirm this is the Pectineus muscle, my target. I tilt the probe up until I find the bone. Once I bind the bone, I inject the fascial plane just medial to the bone. I think this is clear. Okay. Okay. It is about the two coming blocks. The two coming blocks, inshallah, they are not used usually for anesthesia, but for energy. First one is called the Ain block, and the second one is the Adductor Canal. So we will see these two blocks, and the third one, even the Ibac block. The three of them usually used for analgesia, not for anesthesia. This Ibac block is a point is what? That's the femoral artery, femoral nerve, give its branches to the hip in this point. This is the eminence here. It's called the pectoral eminence. Then the nerve coming in between these two eminences. So the nerve pass the nerve to the hip joint. It is the femoral branch to the hip joint. So this block does not make resultant motor block. How to find this? I'll show you on the screen. So this is the bony landmark for this block. We'll show it now. Then on the some images about it. Then we'll go to the patient how to do it. This is the bony block. As you can see, this is the anterior iliac spine, and this is the Pectineus eminence. It's just elevation of the bone at the site of the attachment of the Pectineus muscle. And between these two elevations, there is a gap or a depressed area where the psoas tendon is running. The nerve to the hip from the femoral nerve coming, the branch of the femoral nerve going to the hip is running in this area. So according to Dr. Bing, if you inject local anesthetic here, you block this branch of the to go into the hip. It's commonly used for chronic pain and can be used for hip pain for fractures. So in the case of fracture, you want to position the patient or you want to give even analgesia after surgery. The beautiful of this block, that is an articular block. You block a branch to the joint. So it's not associated with motor block. That's why this block is getting more and more popularity. So again, this is a Bing block where the nerve, the articular branch or the hip articular branch coming from the femoral nerve is running deep to the psoas tendon or psoas muscle in this area between the anterior iliac spine and the pectoral eminence. And that's what we'll see on the picture. But in this block, it's we use a curved block, not like the other three nerves we blocked with a linear block. We have to use a curved block.
Stop sharing.
Stop sharing. How we do this block? We just will scan again. We identify the femoral artery and we identify the femur bone deep to the femoral artery and just go slightly superficial, just slightly few 1 or 2 centimeters, just in cephalic direction with the same tilting like inguinal crease. We'll find these two elevations and this is the block and that's it. It's a very simple block. So again, the mark directed to the left. We just want to see where the femoral artery. Look, this is the femoral artery and this is the bone. We just go up few centimeters and that's it. This is the target point. Clear? Again. So this is the femoral artery and this is the femur, curved bone. Once you go up, it becomes straight. And you can find the two elevations, this and this, and the psoas tendon is between. For acute pain, you go with a needle from out of plane like this. For acute pain, we don't care about the needle directions. So we put it from lateral to medial to avoid injury of the femoral artery, like this. Okay, but for pain, the needle is burning by the tip, so you have to make it like this. But this not for an acute. Acute pain, we just make it as simple as such. So again, this is our target, the femoral artery. Look down to the bone. This is the femur bone. Just slide the probe with the same oblique. Then you'll find the anterior spherical spine, Pectineus eminence, and this is the psoas muscle. So this is Bing block. As I said, this Bing block is used for the pain control for hip fractures or for the pain control of hip surgeries. As I said, it's not induced motor block. That's why it's gaining popularity these days. And also it can be used for chronic pain. If the patient have chronic pain, you can burn the nerve and the femoral branch to the hip at this point. Let's go to the next one. The two branches here from the femoral nerve, it's divided by the branch. By the way, I forget to say that once you find the femoral nerve, if you go slightly distal, you find the nerve break down into many branches. So whenever you find the femoral nerve break on the any branches, sometimes this happens at the level of the inguinal crease, of the skin crease. So you go slightly proximal. So you block the nerve where the nerve is one piece. Sometimes the artery is one artery, sometimes it's two arteries. I don't care personally. I care about the nerve. If the nerve is one piece, I block the nerve, femoral nerve at this position. If the nerve drop to or break into many branches, I don't block the nerve at this level. I go proximally until I find the nerve. The femoral nerve is one branch. I forget to say this during the femoral nerve block. Now, during the adductor canal too, after the nerve of the femoral nerve will break into many branches, two of these two branches running between going with the femoral artery, which is divided into superficial branch here and the deep branch here. This is called deep profunda, and this is the superficial femoral artery. So the superficial femoral artery and the superficial femoral vein, and two branches from the femoral nerve, which is the saphenous nerve, and nerve to vastus medialis are going together here, as you can see here. This area is overlapped by the sartorius. Sartorius muscle coming, subhanAllah, from anterior spherical spine laterally to be inserted in the medial aspect of the tibia, medially. So it crosses obliquely the leg. At this region, it passes above the artery, changing this compartment or this space here into a compartment. As you see here, this is the sartorius muscle, slightly overlapping the artery. In the medial side of the muscle, you can find the space between adductor longus and vastus medialis. And this is the artery, which is superficial femoral artery. And note that the superficial femoral vein is below the artery. This small one is the superficial femoral vein. And the two nerves, the saphenous nerve and nerve to vastus medialis, running in this area. The saphenous nerve sharing in the supply of innervation around the knee, and nerve to vastus medialis sharing in the innervation of the knee. So this block is used to give some sort of analgesia after total knee surgery. It is not like femoral block by any means. Femoral block give more analgesia, but the problem with femoral block that is block the whole quadriceps muscle. In this block, you block only one branch of the quadriceps muscle, which is the vastus medialis. By the way, if you inject the block very proximal here and you inject a huge amount of local anesthetic, 20 ml, 25, you will block the femoral artery. So if you want to do this block and spare the motor power as possible, go down and do this block at this level. Okay, so this is the adductor canal block. So in the adductor canal block, we block two nerves, the saphenous nerve and the nerve to vastus medialis. And this gives some analgesia to the knee, but it's not anesthetic to the knee. You can use this as an anesthetic to the saphenous nerve, but not to the knee. Okay. So let's see this block on the screen and come back. And inshallah, if some people will come late, if they want me to repeat anything before I go to the lateral position block, sciatic, inshallah, I can do it. Inshallah. Stop this share. We'll scan from up to show the anatomy of this is as you remember, we said this sartorius muscle coming from lateral going medial. If you concentrate here on the muscle, as I go down, the muscle going medially, as you see. As I go down, the muscle going more and more medially, more and more medially. So this is the sartorius muscle. On the medial side, you can find adductor longus. For the lateral side, you can find vastus medialis. But actually, the name is not important. The most important, this is the structure which I like, which is a landmark for this technique. So we place the probe in the mid-thigh level, and then looking for the artery, which is a superficial femoral artery. The note that is the vein is below the artery. In this area, the femoral artery and the inguinal crease, the artery is just lateral to the vein. So vein, artery, nerve. in this area, the vein become deep to the artery. So this is the artery above and the vein below. Okay, the vein is collapsible. Look, I can collapse the vein, but I cannot collapse the artery. Look, the vein, I can collapse it. So this is superficial femoral artery and this superficial femoral vein. Regardless the names, you inject the needle either in or out of plane and inject local anesthetic lateral to the artery in this area. It doesn't matter if you want to do it in plane, do it. If you want to do it out of plane, do it as you like. So this, to me, I come with a needle here. Try to be between the muscle. Yani I prefer to go in plane because in plane give me advantage to run between the two muscles. So this give me less hematoma because usually after TKR, the patient take Lexan and anticoagulant. So I don't like to go through the artery if possible, through the muscles if possible. So I don't like to go like this. It's better to me, not with everybody, that I can go between the muscle in this fascial plane. So this is the adductor block. It can be used, as I said, for so for my technique, I go like this and inject it from here. Okay, some others go out of plane and inject it like this. So whatever you prefer, it doesn't matter. To me, I think it's more safer to go in plane because you can see the tip and to avoid the muscle injury. The next block so this block you can use it for the knee, as we said, or for any surgeries below the leg if in the medial side. If you want to block the saphenous, this is one of the best areas to block the saphenous, but you have to inject high volume. This is a fascial block. And if you block the saphenous nerve down, you see the nerve and you can block it by 5 ml. So the difference between blocking the saphenous here and here, the first, the volume. Second is the distribution. If you block the saphenous here, you block from here, the whole skin from here to down. But if you block the saphenous here, anesthesia starts from here. So if the surgeon is the proximal to 1/3 of the tibia, you don't have a choice. You have to block the saphenous in the adductor canal. Okay, let's go the next to see the next block, which is also analgesic block, which is the Ibac block. Ibac block, the idea of it to block the branches of the sciatic nerve to the knee joint. The branches of the sciatic nerve penetrate the posterior capsule to enter the joint and to supply the structure inside the joint. So if you do the Ibac block, it's one of the techniques that you can anesthetize the branches of the sciatic. I'll say again, it's not 100% effective like the sciatic nerve block itself, but it gives, as I said, some sort of analgesia better than morphine alone or better than no blocks. This Ibac block can be done in the supine block, and this is the original technique, and also can be in the lateral position. So we'll describe the supine technique, and then we will go down to there. So next, our block also is an analgesic block. It's called Ibac block. It's just tissue infiltration, it's just fascial gland infiltration to the posterior capsule of the knee, just to block the some branches coming from the sciatic nerve and from Octolytical, which penetrate the posterior capsule. It can be performed in the supine, can be performed in lateral, as you like. In the supine position, you just put the leg, the patient leg at the figure of 4, and you can tilt his hip slightly to rest his, as you can see, to rest his leg and thigh on the bed. So the thigh and the leg is still. It's used curved probe from this point. And what you are seeing here, after the superficial femoral artery and vein crosses the adductor hiatus foramen, it becomes in the posterior compartment to form the popliteal artery and vein. And then they join the sciatic nerve in the popliteal fossa, where we block the sciatic nerve. Deep to the artery in this area lying the capsule of the knee joint. This is the femur, and here in this area is the capsule. The idea is just to infiltrate local anesthetic just deep to the artery, and that's it. That's it. It's very easy block. Just block the local anesthetic deep to the artery. So this is the artery here, and this is a vein. We just block local anesthetic deep to the artery. I will also describe the next block, which is sciatic nerve ankle block, which also performed in the supine position. Then later I'll describe the lateral position blocks. The sciatic nerve at the end of at the foot level divided into 4 branches. 2 superficial, which is the sural and the superficial femoral, and 2 deep, which is the deep peroneal and the posterior tibial. The only one is visible in all patients is the posterior tibial nerve. The others are very small nerves and usually not seen, except very rarely you can see it in some patients, but not common. Yani in myself, I can see my sural, but I cannot see my deep nerve. But the point, the block is very easy. The three nerves, we block them in superficial blocks, just local infiltration. And the deep two nerves, this is the first one of them, which is the deep pronaal. The posterior tibial. It lies, this is the posterior tibial here. It lies posterior to the vessel, just posterior to the medial malleolus. So this is the medial malleolus here, and this is the posterior tibial vessels, and the nerve is just posterior. It's a very easy block. The other branch, which is the deep branch, is called the deep pronaal nerve. It's also related to the dorsalis pedis artery. But actually, in some patients, it's lie medial, some patients lie lateral, so I inject both. I put 2 ml here and 2 ml here, and that's it. So I infiltrate the local anesthetic in both sides of the anterior tibialis anterior artery. So this is the two blocks which we do it usually with ultrasound in the ankle block. The deep pronaal artery, deep pronaal nerve, and the posterior tibial nerve. The other three superficial nerves, which is the saphenous, superficial pronaal, and deep and sural nerve, we block usually the superficial pronaal routinely, and plus saphenous or sural or neither, according to the site of surgery. Let's go and see it, how to do. Yes, sir. Yes, sir. So we'll stop with this share area. So we make the patient. Remove it. Okay, we make the leg in the figure 4. Figure 4, that's like this. So you open the medial aspect. And if you need, you can just tilt the hip like this. So this resting on the tip. Then use a curved probe, just one finger above the patella, and that's it. So in this position, you can identify the vessel, and you direct your needle between the vessel and bone. So this is a position. Look, as you can see, this is the superficial femoral vessel going from the anterior compartment here to the posterior compartment. If you go deep, you find this nerve vessel going down. Okay, you can see it. So this is still in the side anterior compartment, and now it's crossing the adductor hiatus, very clear in this patient, and going to join the sciatic nerve. This is a sciatic nerve. It's a very good anatomy in this patient. Okay, once you go on this level, we can block. We go to the needle from here directed to posterior to the vessel. Posterior to the vessel. Okay, so again, this is we follow the vessel. If you can follow the vessel, you find the vessel here superficial, it's going deep to join the nerve, the sciatic. Once you find the level, the vessel going deep in the posteropopliteal fossa, then we can pass the needle out of plane or in plane, directed. But I think out of plane would be better in this block, directed posterior to the vessel. So again, here in the ultrasound here, this is a superficial femoral vein and vessel. There is an artery. This is post 2. I make some colorful color. So artery and vein. If you follow them down, you find they're going to the posterior compartment to become, and now they are named the popliteal vessels. Now they are named the popliteal vessels. And with the sciatic nerve, superficial or posterior to them. Just to describe the anatomy, superficial here is anterior, medial, down is lateral. And for this side of the image, this is anterior, and this side of the image, this is posterior. This to describe the anatomy. So this is image. Above is medial, show them here. So above is medial, to the mark is anterior, and the other side is posterior, and down is lateral. So again, here, as you can see, the artery is above, going to the adductor hiatus, then going down. In this area, the vessel coming down to become accompanied by the sciatic nerve. What you to go, just posterior to the vessel here and inject your local anesthetic. Just between the femur, this is the shaft of the femur, the back of the femur, and this is the vessel. And always, always, always in all blocks before you insert the needle, put the color Doppler to see if there is any vascular structure at the site of the bus of the needle, to be sure that you'll not harm any vessel. Okay? So this is Ibac block. Now we are going to the ankle, as I said. Okay. The ankle have 3 superficial branches started by S. The saphenous going anterior to the medial malleolus, and then superficial peroneal in this area, maybe divided in many branches. Then shoulder coming between the lateral malleolus and adductor and this tendo Achilles. In some patients, you can see the shoulder, but it's not routine, as not needed. Yeah, just local infiltration like this, it will block this branch and block this branch and block the saphenous. What we need to use the ultrasound to see the posterior tibial nerve and artery. We put the ultrasound here. We will find first the artery, then just posteriorly to it, we'll find the nerve, as we'll see now. So the mark directed to the left always. So the mark directed to the medial, medial malleoli. We'll find the vein, vessel, then the okay. So this is the posterior tibial nerve. نشوف الجروب الثاني احسن. Okay, same, almost the same image. So here the vessel, and just posterior to the vessel you can find the posterior tibial nerve. The same for the dorsalis pedis here. We just identify the dorsalis pedis and we inject at the 2 sides of the 2 aspects of the nerve. The patient is small, so I use a tiny probe. This is the artery, and we inject in both sides. I cannot tell it's slide medially or laterally. I don't know. So what I'll do in this case, I will inject in both sides. Actually, I do this block in this. First, I do the posterior tibia because I have to do it in all ankle blocks. Then I put the needle like this. Then I put the needle to get the deep peroneal. Okay. Then I directed laterally to block from the same puncture to block the superficial femoral. Then, if the surgery in the medial side, I'll go to block the saphenous. If the surgery in the lateral side, I'll go to block the sural. If the surgery in the middle, like amputation of this toe, I'll not block neither. So the 3 routine is the posterior tibial, the deep peroneal, and superficial peroneal. They supply skin and deep structure. Because some people think that the deep peroneal only supply this whip area of the skin. Yes, this is a cutaneous innervation, but it also has deep tissue innervation. So I block the superficial and deep peroneal routine through 1 injection here, first to the in the 2 sides of the artery. Then I'll make it superficial to block the superficial peroneal and block the posterior tibial. If the patient is still with surgery will be in this side, like in correction in the bone defect here or bone gap here, so I go medially to block the saphenous nerve. If the surgery in the lateral side, the skin side, only skin aspect here. Now, if here it's khalas, this is superficial peroneal. But if here this, I need sural. So I go to block the sural between the lateral malleoli and tibial Achilles. Maybe in this patient we can see the sural. Let's see, but it's not common to see the sural. Yani, it's not a common thing to see this nerve. Bismillahirrahmanirrahim. This is the tendo Achilles. And it's not clear. This is the tibialis muscles. It's not clear. So because the patient is thin and this patient's the nerve is running in superficial fascia, so just give superficial block and it will spread to the shoulder nerve. So the nerve not that clear in this patient. This is the tendon Achilles, by the way. Maybe this is the shoulder nerve. This is the shoulder nerve. Yeah, it's here. But as I said, it's no need to see it. Just inject local anesthetic in this fascial plane, and it will spread down to the nerve. By the way, this is the tendon Achilles. If somebody interested in the musculoskeletal ultrasound, this is the tendon Achilles, and if you follow the tendon Achilles, you can find and compare laterally. You can find any damage in the tendon or any trauma or anything if you want to inject PRP or something. So this is the ankle block. So before we go into the lateral, before we are going to lateral position, I'll check again all blocks. If you have any question, please tell me. Write down here, so I can answer. One friend, Dr. Dia, asked for big block. I repeat it again.
Fascia iliaca and Bing block.
Fascia iliaca and Bing block. First, fascia iliaca is not that important with the presence of ultrasound. Fascia iliaca is fascial gland block, and with the presence, its importance, if you don't have equivalent like nerve stimulator, if you don't have ultrasound, then it can be done by just blocking the needle and pass the two fascia. But in the existence of ultrasound, it has no rule at all. You can block the femoral nerve very easily. You can block the Pectineus nerve very easily. And you cannot, we don't use this huge local anesthetic. But anyway, I'll show you how to do the fascia iliaca. But as I said, I don't recommend this block. You can do femoral and lateral simultaneous very easily. So again, I repeat everything and I'll add this fascia iliaca. Regarding nerve stimulation, I use nerve stimulation only in the sciatic nerve block in the proximal techniques, as I will show in the lateral position, and in lumbar fascia in lumbar plexus block. But in other blocks, I don't use nerve stimulation. This is the location of the femoral nerve, as you can see here. It lies anatomically deep to the fascia iliaca. It was said that if you block the local anesthetic, and it has actually happened, if you penetrate the fascia iliaca and you inject local anesthetic here, this is enough to spread to both nerves. This is an axial section or cross section to block the two nerves, the lateral cutaneous and the femoral nerve. So they do it like what? They go and at the level of the iliacus muscle and put the probe perpendicularly between through the anatomy of this area, you'll find the iliacus muscle deep, and the sartorius, part of the sartorius covered by part of sartorius muscle posteriorly, and part of the abdominal muscle superiorly. So once you inject the local anesthetic just superficial to this muscle, deep to the fascia, this is the fascia iliaca locate. As I said, it is not that important. You can replace it very easily by femoral and by lateral cutaneous. They are more rapid onset. They are less local anesthetic and they are easier anatomy. But we'll see everything again. بسم الله الرحمن الرحيم. خلينا بقى في الايه؟ ستيب شيرنج. انت دائما حاول خلي ايدك لهناك. Look, this is the iliacus here, and this is the sartorius muscle. Okay. Then when we make this probe like this is the femoral artery. If you go laterally, this is anatomy. This is part of sartorius, and this is the iliacus muscle. We inject deep to this fascia. This is the fascia.
Scanning technique, please. Can you show the scanning technique, your hand technique?
Okay, هات لي answer. So we first identify the artery as usual, then the iliacus muscle deep to the artery, then we tilt the probe. This we identify the artery here. Yes. Then this is the iliopsoas muscle, and this is the sartorius, as we said before. Then at this fascia, this level, I will rotate the probe, so it becomes vertical. Come answer. So I make a rotation, and the probe becomes vertical like this. Okay. So the probe becomes vertical like this. Clear? Mm-hmm. So just lateral to the artery, you find the iliacus muscle, and then we rotate the probe. تعالى بقى معلم هنا. This is this is superiorly and this is inferiorly. Superiorly you can find this is a muscle of the anterior abdominal wall, and inferiorly you can find this is the sartorius. So this is the iliacus muscle deep to this fascia. We inject local anesthetic. Okay. So we repeat all blocks again from the beginning. First one is the femoral artery. I'll not show the ultrasound probe. I will show the screen always. خليك بقى مع screen يا آسف. So all blocks here, all of them started by the femoral artery. Here the femoral artery. Then we look laterally to identify if we need the femoral vein nerve. We look laterally, and we tilt the angle. We tilt the probe until I find the best angle or the best shape of the nerve. As you can see here, the nerve is. This is the best image I can get. Triangular shape with the apex directed laterally. If you go slightly down, you'll find this nerve divide into many branches. So we don't like to block it at this level. We go up to block it at single one nerve trunk. Okay, so this is how to identify the femoral nerve. If you want to go to the lateral femoral cutaneous, so first we'll identify the artery. We'll go lateral to identify the medial tapering end of the sartorius muscle. We follow this sartorius muscle laterally until its lateral curved border, and on the curved border we find sockets with the lateral femoral cutaneous nerve. In this fascia socket. In this one we find two here, one in here, one. It's very minute nerve. Okay. So this is the lateral femoral cutaneous nerve. Then, if you go to the obturator, we'll do the same. We identify the artery. We start with identifying the artery. We go medially step 2 to identify the Y-shaped muscle. This, by the way, the anterior obturator nerve. But we will not block it here. We will just tilt. So we confirm this is the Pectineus muscle. We will tilt the probe until we find a bone deep to the muscle. Then I'll inject my local anesthetic here, proximal interfacial technique. I don't need nerve stimulator. I'll go in this area. I'll go lateral out of plane. In the femoral lateral cutaneous. In the lateral cutaneous, you go as you like. In the femoral, I usually go in plane. For fascia iliaca, I'll go again, femoral artery is the starting point of all blocks. This is the muscle. So this is the iliacus muscle. I'll go make rotation to identify the muscle. This is the sartorius, overlapping part of the muscle, and from the other side, this one is the anterior abdominal, and anterior abdominal muscle. And as you see, this lymph node, by the way, this lymph node. So by the way, as you see, this fascia iliaca is thick in this position. I go deeper to this fascia and start the injection. It's not that femoral and lateral cutaneous, to my opinion, is far important than this block. As regarding Bing block, we put the curved probe, Bing block for acute pain. We use the curved probe, then we put it as we identifying a femoral vein, nerve and artery again. Same like femoral artery. Then I will identify this one, the artery, femoral artery. I am now on the skin crease. This is the bone curved here. I go slightly above. Then you find the two ends with the psoas muscle in between. So this is the site of injection. I go with my needle from here, direct from the acute pain, we do this. So I prefer to go with the needle from here. I go to the bone and inject on the bone as you like, 5 ml, 10 ml, as you like. So it's this branch, this block, it's said that is give a good analgesia for fractures and also after hip surgery. But I don't care. In my hospital, we don't have a problem with giving motor block. So the patient take femoral, sciatic, and obturator in hip surgery. As inshallah, tomorrow, inshallah, I describe, inshallah. So this is the Bing block. This is analgesic block, is not anesthetic block. So we'll go down to the adductor canal block. We use a linear probe. Again, we go to the mid-thigh level. We want to identify the superficial femoral artery and vessel, superficial femoral vessel. This is our landmark. We put the leg in the figure 4 and we scan this area. And the target is the vessel here. Once you find the vessel, just be sure that to see the vein, because sometimes the vein collapses and you may harm the vein with the tip of your needle. So just identify the vein. As you can see, this is the artery and vein. This superficial femoral artery and vein. This is the vein in blue. Okay, and the artery is the one above. We want to inject lateral to the vessel. okay, you can go in plane or out of plane as you know. If you make this block more proximal, you may get more branches of the femoral nerve blocked, giving more analgesia, but also more motor block. If you go down next to the Ibac block, it is one of the analgesic block to the knee. It can be performed like popliteal in the supine or lateral position. If you do it in supine, you do it with the big probe. You place the ultrasound here, one finger above the patella, just to identify the superficial femoral vessel as it transmits to become the popliteal vessel. Just changing the name. So this is a vessel here, and if you don't see adequately, you can just switch on the color dome. Then follow this vessel down, slightly down, until it becomes close to the sciatic nerve. This is the sciatic nerve. You can go with the needle by injecting local anesthetic deep to the artery, between the artery and the femur, okay, the shaft of the femur. So this is Ibac block. Also, some analgesics can be given into the knee. You can inject intra-articular. Surgeon can give a technique called local infiltration, called LEA technique, local infiltration anesthesia. So many blocks can be used to provide analgesia to the knee if no motor block is accepted. But if motor block is accepted, خلاص, give the routine blocks as inshallah tomorrow. Inshallah, I'll see you in the lecture. Inshallah. Then we go down to block in the supine position the ankle. The two nerves that we block them by the ultrasound, mostly the posterior tibial. We put the ultrasound probe posterior to the medial malleoli here. Then we are looking for the artery. So the posterior tibial artery is our landmark. And posterior to the posterior tibial artery, we'll find the. So this is the posterior tibial artery, as you can see. And posterior to the artery, you can find the nerve. It's very clear. Posterior to the artery. Okay. The deep pronaal is lying also in relation to the artery. So our landmark here is an artery, which is the tibialis dorsal speedus artery. So we are looking for the artery here, and we inject in both sides. And as you see here, this is a trick. This is a vessel here above the artery. So that's why you have to make color Doppler every time you insert the needle, because there may be a vessel you harm it. Okay, so this is the dorsal speedus here. Okay, so we inject in the both sides of the artery. We inject in the both sides of the artery, okay, for blocking the deep pronaal. We use the same puncture, skin puncture, to direct it medially, laterally to block the superficial pronaal. If needed, we'll direct it medially to block the softness. Then lastly, we inject here the lateral, if the lateral surgery in the lateral aspect of the foot, we'll inject shoulder. If not, no need. Okay. Now we're going for the lateral blocks. So we'll take 5 minutes break until we position our. Right. Now we are going to the sciatic nerve. Sciatic nerve هنبتدي من تحت لفوق, from down upward, which will start with the popliteal block. Usually popliteal block is performed in the lateral position, although it can be performed in the supine position. But this advanced technique, if anybody needs it, I can describe at the end of this workshop. We start with putting the ultrasound probe here at the level of the crease. At this level, as you see, the sciatic nerve divided in two branches, the common pronaal and the tibial nerve. The tibial nerve goes with the artery. Both of them go to the middle. They cross in the middle. While the common pronaal nerve goes lateral. So what we can, we usually block the nerve at this point of bifurcation, either before bifurcation or at bifurcation or just shortly after bifurcation. This bifurcation level is variable between patients. So how to define this bifurcation level? We start by putting the ultrasound in the crease. We find the tibial nerve, and with the vessels, usually the vein is superficial to the artery. So the one below the nerve, vein nerve, tibial nerve is a vein, not the artery. But anyway, it doesn't matter yet. So we identify the tibial nerve superficial to the vessels, and then we follow the tibial nerve proximally until we find the other branch, which is common pronaal joining. So that's what we do. This is the tibial nerve here, and this is the vessels. So we follow it upward cranially until they join each other. In this nerve and in the femoral nerve, these are two important nerves, tilting of the probe, improving the image. But in this case, we'll tilt the probe caudally. We'll tilt the probe caudally, okay? So let's see how to do this kind of block, the popliteal block. Let's stop sharing. In lateral position, we always put this mark lateral, upward. So upward will meaning lateral. The operator side will be upward. Usually people stand behind the patient. Exceptionally in this block, I prefer to stand here on the other side. I'll show you how to do it. But anyway, we'll start first by identifying the artery. So we put the probe, this is a crease. So we put the probe first on the crease to identify the tibial nerve. Then we follow, then we follow the tibial nerve proximally until it joins the common peroneal. They become one artery. Tilting the probe like this is giving a picture, improving the picture. So don't forget to tilt the probe. It's try and error. Yani the angle, I cannot say 20, 50, I don't know. Just you try until you get the best image. Okay, so start here, identifying the vessel. Superficial to the vessel, there is the tibial nerve. Follow the tibial nerve proximally until it joins the common peroneal. Tilt the probe to get the best image. Let's go. Okay, so as you can say, this is a vessel, and superficial to the vessel, this is a tibial nerve. What we'll go, we'll follow this nerve, but when you follow it, it becomes deeper. So follow the nerve, this tibial nerve, until it joins the other common peroneal nerve. This is a common peroneal. So we both join each other. You see this division point? So this is the common peroneal, this is the tibial. Now they become two nerves. This one of the branch is the Schurer branch, but anyway, yeah. This, the common peroneal, it's Schurer branch, and this is the tibial. They join each other here. So this is the point where I prefer to block it before division, but it's up to you. So if you tilt the probe, if this is the perpendicular, and this is if you tilt. So if you tilt, you find a slightly better image in this patient. Okay. How to put the needle? Most of operator, most of operator put the needle like this. But this is not easy. I prefer to put the needle slightly distant from here and put it like this. Okay. So the needle on the screen will come from here, back like this, not from here. The screen needle will come here, but this needs some experience. So I prefer to go from here. And to have a better needle handling, I stand, but only in this block, I stand here. So I do the block in this way. But the ultrasound will be here. But this is exception in the popliteal, and this is only my preference. Not everybody does this. So what I do, I find the artery, to find the nerve, I go with the needle like this. To me, I think this is better handling for me as well. I put the ultrasound machine on the other side. But most of other operators stand in the other side like this. You can insert the needle like this. You can insert the needle out of plane if you want. Also, out of plane. You can insert it in plane. I insert it in plane from lateral aspect. This gives me a chance to be the needle more horizontal and give better resolution of the needle, but alignment of the needle is needed some experience. So this is the problem with this point of the needle. Okay. So this is the popliteal block. Inshallah, tomorrow we'll describe indication for popliteal block. Then we're coming to the block is difficult one, which is the subgluteal block, subgluteal sciatic block. We'll see it here in the shared videos because in this position the sciatic nerve is not related to a big vessel and not related to a bone. So identification of sciatic nerve depends on the fascial grid. How we identify the sciatic nerve? I call this a rotator flat float flask appearance. As you see here, this is the sciatic nerve coming at the level between the greater trochanter and ischial tuberosity. In this area, the sciatic nerve lies between the gluteus maximus muscle, this one, superficially, and deep is the quadratus femoris muscle. And from the medial side, you can find the common hamstring tendon attached to the ischial tuberosity. So this is a sonographic anatomy. You can find the sciatic nerve here. This is the sciatic nerve, and between the gluteus maximus superficially, and this is the quadriceps muscle deep, and as you say, the common hamstring muscle. If you see the fascial plane of these three muscles, it gives you like this shape of rotator flask. You know this champagne flask or flute flask? This is the shape. So I called it rotator flask appearance. The cup here is the represent the common hamstring tendon, and this line is the fascia between above the gluteus maximus and gluteus and the quadriceps femoris. The sciatic nerve is the center here. So this is how to identify the sciatic nerve as the subgluteal area. But the problem, so this is a flask. If you rotate it, it will become similar to the champagne or the flute flask. The problem with this block, and this makes providing anesthesia is not easy, that this is a fascial plane identification. In obese patient, you will not see any fascial plane. Everything here will be white, and identification of nerve will be difficult. And if you don't block the sciatic nerve, you cannot achieve anesthesia to the knee. You cannot achieve anesthesia to the blue knee. It's difficult to achieve anesthesia without sciatic nerve. Or above knee amputation, blue knee amputation, no way, you have to block the sciatic nerve. So blocking sciatic nerve at this level in obese patient, which is the most usually diabetic or obese, so it has become difficult. So this is the sciatic nerve subgluteal area. That's why I make, alhamdulillah, I publish another technique. It's called parasacral technique. I published 2012. In this technique, it relies on one idea. The sciatic nerve is going from the pelvis to the lower limb or gluteal region through an opening here, which is called the greater sciatic foramen. In this point, that crossing the greater sciatic foramen, it is direct contact in the bone. And this is the only position of the sciatic nerve all over the body. It is in direct contact to the bone. So I use this anatomical landmark or anatomical information, and I describe a block here to block the sciatic nerve within the pelvis, just at the time it is going out to the gluteal region. So the point is to identify this bone. In this image, you can see the sciatic nerve, but even if you don't see the sciatic nerve, even if you don't see the fascial plane, just you find the greater sciatic foramen border, which is called posterior border of ischium. Once identified, you just direct the needle just medial to this bone, and you will find the sciatic. This is called the parasacral technique. So the parasacral technique relies on identification of the curved bone. So unlike the subgluteal, which has no good landmark, this technique has a good landmark, which is the posterior border of ischium. Characteristically, this bone is curved. So you are looking for a curved bone. Once you find it, without even try to identify the sciatic, insert the needle just medial to this bone. Out of plane, just medial to this bone. Slowly with nerve stimulator until you get twitches of sciatic nerve, adjust the needle position and start injection. So this is a parasacral technique. Inshallah, tomorrow, inshallah, I will compare between this parasacral and subgluteal, which one should be used in different surgery. Let's see these two blocks. Then inshallah, we'll go to the lumbar plexus block. Okay, stop sharing. As I said before, always the marker directed upward, which is lateral. So what you see on the screen to the left is lateral, and what you see on the right is medial. This is the greater trochanter here, and the ischial tuberosity is here. So go to ultrasound group in between, and then let's see what we have. Okay. So we put the probe here, and we try to tilt the probe up and down until we find this picture that I told you about it. Okay. Freeze the screen. As you see here, this is a common tendon, this one, and this is gluteus maximus, and this is adductor brevis, and this is the middle. So in the center, this is the sciatic nerve. So this is the sciatic nerve lying just lateral to the common hamstring tendon. You can tilt the probe superior, inferior, slightly move it until you get a picture. So I'll try to do this to get a better image. خليك هناك. Okay, so this is a better image, I think. Please, yes. So this is a better image, but as I told you, this is not reliable even in this same patient. The fascial plane, because it's have some fatty and the nerve is fatty, you cannot differentiate adequately between the nerve at this point. So that's why I prefer to do the parasacral technique. So this is the sciatic nerve at the subgluteal region. We'll go to the parasacral because I'm interested very, I love this block too much, very much. So for the parasacral, تعال بقى يا سيدي هنا. Leave your hand. Okay. Okay. For the parasacral, we start at the level of the upper end of the gluteal cleft. So this is the horizontal level where I'll find this curved bone. And we put four finger, and this is my starting point. So in 95%, I'll find this curved bone at this point. Okay. Okay. Okay, that's it. So this is lateral and this is medial. As you can see, this point, this curve is the curved bone I told you. Just medial to it, you'll find the sciatic nerve. What to do? Go with the needle out of plane and insert the needle like this. So this is the sciatic nerve, as you can see here. This is the best image I can get to the sciatic nerve. You can see this is the piriformis muscle if you want to do piriformis block, and this is the sciatic nerve. Just medial to the bone. Even if you don't see the nerve, it doesn't matter. Go with the needle just medial to the nerve, medial to the bone, and switch on the electrical activity. Once you hit the nerve or touch the nerve, there's impulse or twitches you can identify. So in this block, just go medial to the bone. Again, so this is the curved bone. Again, you have an answer. So you put the probe here, forefinger at the little of the lateral end of the cleft, and this is the starting point. Then you can adjust the probe according to the image. Then what to do بقى? Okay, once you bring the nerve in the middle of the screen, so try to adjust the rocking angle until the nerve becomes in the middle. Once the nerve in the middle, push the needle in the middle of this one and align connecting the middle of the probe to this wire. If you do like this, you will hit the nerve 100%, even if you don't see the needle tip. So go like this, slightly, push slightly until you find in the middle. Look between this and this. If you do like this and the nerve in the middle, for sure you will hit the nerve by out of plane technique. So this is the nerve. Now the nerve is not in the middle. I rock the probe until the nerve is in the middle. You see, now the nerve is, I pass the needle like this, it will hit the nerve 100%. Look, the needle will pass like this, like this, like this, like this, like this. Then it will kill it. So that's how we do the parasacral technique. So again, we put the nerve in the middle by adjusting the rocking angle. Then we put the needle in the middle and like this. Look to the line, this line connecting the middle and the middle. So if you do like this, the needle will hit the nerve. Okay, even in a morbid obese, even I do it in some patient with 15 centimeter depth of the sciatic. I don't need to find the sciatic. I just need to find the bone and direct the needle just medial to the bone. Okay, so this is the sciatic block, the parasacral technique. Lastly, we'll go to the most advanced one of them, which is this is the anatomy of the lumbar plexus. As you can see, this is spinous process. This is the lamina. This is the vertebral body. And here you can find this is psoas muscle, and this is erectus spinalis muscle, and this is quadratus lumborum. The lumbar plexus lie within the psoas muscle. But if you try to see it directly posteriorly like this, the lamina will obstruct the view. So what we go with the probe slightly lateral, then we rock the probe medially. So we see this between this black line. You see this area? This is what we'll see in the probe, as we see here. So what I'll see, the view will be in the screen, the spine process, lamina and body, and the erectus spinalis and psoas muscle. If you just remove all the structure except the bone, you find that the bone make like wave sign. I call this the wave sign. So the lamina and the body make like a wave. So this is a landmark for the block, the wave sign. I want to show you the anatomy clearly. So, sorry. If you can find, so why it doesn't come? So we identify the wave, bony wave, two elevation of the bone, and between these two elevations, small defect. This is the intervertebral foramina. Just lateral to the body, you can find the lumbar plexus. And most of the time, you find associated with some blood vessel in this area. And I usually go in plane, so I insert the needle 3 centimeters away from the midline and pass it slowly until I find lumbar plexus. If you sway, because lumbar plexus, you see it's a deep block, so I need electrical stimulation to be sure that I'm not injuring the nerves. So I go slightly, slowly until I become close to the lumbar plexus. I'll start to adjust my nerve stimulator current until I got adequate response. But as I said, this block and the paravertebral block, both of them is a deep blocks, and you need nerve stimulator to adjust the needle tip, okay? Because it's too risky to give a block, because if you are not close to the nerve, the block will fail, and if you are inside, you will harm the nerves. So by ultrasound, it cannot 100% be sure that you are outside the nerve in these deep blocks, okay? So in these two blocks, the lumbar plexus and the sciatic, the parasacral, especially the parasacral, I use routinely nerve stimulation in addition to the ultrasound. Let's see what we'll do with the lumbar plexus. I'll mark something, but I'll remove it up before I leave it, okay? So first, to identify the level. This is the iliac crest level, so we go like this, and this is the midline. 3 centimeters away from the midline, you can make it by measure and or the needle. So this line will be insertion of my needle. This is the same as landmark for nerve stimulation. So where is the 3 centimeters? Okay, so this point will be the needle insertion. But anyway, we'll put the ultrasound probe now to see the anatomy inside. The same, the mark will be lateral, and I'll put it lateral 3 centimeters away. Then I rock medially. If I find that I am above a transverse process, so I'm not seeing anything, I'll go slightly down. Okay, to get the image I described. Look, so this is a transverse process, as you can see. So I'll go slightly down, and this is a spine process, and this is a facet joint here, and this is superior articular process, and this transverse process. This is erectus spinalis, this is quadratus lumborum, and this is psoas muscle. But I cannot see lumbar plexus if I am at the level of the transverse process. So what I'll go slightly above. Now I don't see the transverse process. You cannot see this anyway. So I go slightly down. Now I can see the wave sign. You see these elevations? This is the wave sign. Okay. Then This is the lumbar plexus. So I go with the needle slightly like this, and as I said, just lateral to the body. This is the lumbar plexus. Many times you can find some vessels here, and sometimes I'm not sure we can find it in this patient. So in this area, but be sure before injection. So again, this is a transverse process. I go slightly down until I find the wave sign. I know more transverse process, and the lumbar plexus is just like the thin, like this, just lateral to the body of the vertebra. Okay. So this is the blocks for today, and any question I'm happy to answer.
Yes.
ايوه.
في حد عنده
سؤال يا فندم؟
Do you combine adrenaline with this block?
Yeah, adrenaline usually used for as IV marker. Because not we use narpen or ropivacaine, so already have a vasoconstriction activity. So the duration of the local anesthetic is not prolonged by the local adrenaline, not like lidocaine. The same for the toxicity. You cannot use higher dose if you add adrenaline. So adrenaline does not allow you to use higher dose, as does not prolong the block. It's only as an IV marker. So if you inject the local anesthetic, which add adrenaline, which as adrenaline is added, if you are inside the vessel, so it gives you tachycardia, and so you have to stop. Long time ago, we have our lidocaine is already mixed with adrenaline, so we use this kind of lidocaine addition to naropin to do the blocks. But 1 or 2 years, this is formula is not available a lot, and so we don't add adrenaline routinely. But as I told you, it's only for IV marker. By the way, adrenaline itself have toxic effect on the nerve. And all local anesthetic has toxic effect on the nerve if used in very high concentration. This is called chemical toxicity, chemical nerve injury. But as I said, this is in very high concentration, not in the concentration used. سؤال تاني يا دكتور سعد؟
There's some question about metatarsal amputation. Is it enough to anesthetize the sciatic nerve popliteal approach only?
For which surgeries?
Metatarsal amputation. This is a question.
For foot surgeries, look, the point is you can do popliteal, you can do ankle. But if there is sepsis and edema and something, the tissue inside the ankle joint is not healthy, and also the tissue acidosis may not make the local anesthetic working. So at this point, I prefer to make popliteal. But if it's the tissue is healthy, خلاص, ankle block is faster onset. And inshallah tomorrow I'll make a full comparison between the ankle and the popliteal block in the metatarsal, in the tarsal for foot surgery.
Thank you so much, Prof Ahmad, for this wonderful workshop and from eminent anesthesiologist in the field of regional anesthesia. And Dr. Saad, if you have
I'm really overwhelmed by our colleagues who are supporting us for this webinar. More than 140 colleagues are staying with us. It seems that really very interesting. I learned a lot from this workshop myself, and I'm sure a lot of people learning a lot as well. And passionately, we are waiting for your excellent lecture tomorrow.
One more block
on Sunday.
One more block, I want to show it before. It's anterior sciatic. Maybe somebody is interested. I want to show them how to do anterior sciatic nerve in the supine position. Okay? Just one, it will not take too long time. The anterior sciatic
nerve. Take your time. We are so proud. We are so grateful to you. And before we finish, we would like to thank our friend, Mr. Yasser, for his help and his volunteering with us today.
Okay. Okay. For anterior sciatic nerve, we place this, the leg again in the figure 4 to make the medial compartment. We place the ultrasound probe slightly here in this region to identify the femur. And the nerve is just medial to the femur. So this is a good landmark because it's closely related to the bone. Then after we identify it, we tilt the probe longitudinally to identify it more cephalic if you want to do a more cephalic block. But this is reserved to selective cases. Yani we don't use this technique routinely. Only if the patient cannot move, if the patient under general anesthesia, and I want to do sciatic, if the patient is covered after surgery until here, so I don't have access to the popliteal, I do the sciatic in the supine position at this level. Okay, so as I said, we put the ultrasound in this area to identify the nerve. Okay, as you can see, this is a bone, and this is a nerve. This is, by the way, adductor magnus muscle. Okay, then we can mark it longitudinally. Like this. So this is the sciatic nerve, as you can see, this one. You see this fiber? This is the sciatic nerve. And by the way, this is the quadriceps femoris muscle when it's seen from front. It's not common anatomy, not known anatomy, but this is the adductor magnus, and this is the quadriceps femoris muscle when seen from front. So this is sciatic nerve here. This one. So again, if you want to block the nerve, just put the probe here and identify the femur, and just medial to the femur, you can find the nerve. Once you find the nerve, follow the nerve cephalic and tilt the probe again. So again here, as you can see, the nerve, and this is some vessel around the nerve, and this is the femur, just medial to the femur. Then if you want to follow it up, you can follow it up. It's better to make it in longitudinally. By the way, this one, this is this one is a lesser trochanter. But anyway, this is a sciatic nerve, and this is adductor magnus, and this is the perforators. If you have good anatomy knowledge, this is the perforators that's perforate the coming from the superficial femur, from the femoral artery, the profunda, and go through the opening of the adductor magnus to the posterior compartment, the profunda artery. Okay. Thank you so much. If any another question about the blocks, I'm happy to answer.
If you allow me, Dr. Ahmed, I have a comment.
اتفضل حضرتك.
You are a pioneer in this, so my advice to our colleagues to know very well the anatomy and sono anatomy. If you know anatomy, you will know the sono anatomy. You make it simple. You make it simple, yes.
Yes, but even Doctor, if they even start, you can do the blocks. It's in the lower limb. Alhamdulillah, we have safe blocks. It's not unlike the upper limb. You are scared of the pleura, you are scared of phrenic nerve block. In the lower limb, it's just muscles. So I advise everyone to start to do the blocks with supervision of one of your consultants. Inshallah, not big issue in this blocks. You don't afraid to harm vital structure, and also you can give it first in the after as a post-operative analgesia after spinal. In this case, after you give spinal, you will have time because the patient doesn't feel pain, so you can have time to adjust your needle, to see the needle, to perform your block, even if you are a beginner. And at the same time, even motor stimulation will be accessible even after spinal, so nobody worry about the block is. If you need to do spinal after, if you need sciatic nerve after spinal, no problem. The nerve stimulator will be working, no problem at all. The only thing that you lose advantage of paresthesia. So this is my advice. Try to do blocks in all patients after spinal anesthesia. Try to do the adductor canal, try to do the femoral, try to do even Ibac, try to do the popliteal block. Try to make your hand going on in patient after spinal, because after spinal the patient lose the sensation, so will not feel pain, and you can take your time, and the patient will not be annoying with you. But as I told you, you lose the advantage of paresthesia. The patient will not feel paresthesia. Okay. So as I said, alhamdulillah, it's a safe, more or less safe blocks. We don't have a complication related to vital structure injury. But you have still the same complications that's like hematoma, nerve injury, infection if you are doing a patient who's immunocompromised or in chemotherapy. So in this patient, just take the routine precautions. But as I said, alhamdulillah, inshallah, these blocks are very, 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 alhamdulillah, far, far safer than the supraclavicular or scalene or the infraclavicular block. They are far safer than this. You don't have spread, for example, to the brain, like vertebral artery. With lumbar plexus, inshallah, tomorrow I'll describe, but you may get some epidural spread, but not with other blocks.
دكتور احمد there is a comment in Arabic here. شكرا ليكم جدا. شيء خيالي، المعلومه جاهزه لغايه عندك. ربنا يجزيك خير على تعليمك ونشر علم، وربنا يجعله في ميزان حسناتك ان شاء الله رب
انا
العالمين.
بشكر ربنا يجزيك خير، وبشكر زميلنا اللي كان معانا، وبشكر المستشفى عندنا ان هم سمحوا لي يعني ان انا اجي واعمل المحاضره دي. ربنا يجزيهم خير.
اكيد طبعا يعني، وكل الشكر مننا وكل الشكر من الزملاء نيابه عنهم لحضرتك مخصوص والدكتور عادل. In this Saturday social time, second day for Christmas here in the West, I have loads of attendees from the West, and thank you very much everybody for supporting this program. Dr. Ahmad, thank you very much. Dr. Adil, thank you. Thanks to all colleagues. Thank you. See you tomorrow, 7 o'clock Cairo time. Inshallah. Thank you. Thank you, Dr. Adil. Thank you to all colleagues. Thank you.